One of my lines my dad used to always have was, the more things change, the more things stay the same. So we kind of ruined repair. Now we're all back to repair. But those are some great cases, Rick. Thank you. This isn't really that many new concepts because Rick stole my thunder with his first talk. But I really want to talk about, we're going to talk about general multi-leg, then medial side surgery, and then lateral side surgery. So I'm focused more on the medial side and how you think of, let's make the complex simple. These are very complicated cases, and you got to do a lot of stuff. And you kind of see it with some of the Rick's had. We make our problem list, and we just shoot down our problem list. And sometimes the problem list is like, oh, a guy's got a head bump and he's in the ICU. But I always would make my problem lists, talk about my fixation, order of tensioning, and that's how I learned how to do multi-ligament knees. We talked about, whether it's low energy or high injury, the mechanism of injury, how I'm balancing with other injuries are always things. My EUA under anesthesia, that's where I get both my EUA and it's also my stress x-rays. And I always document my stress x-rays. I don't really do stress x-rays in the clinic. I do that very rarely. It's very clinic dependent. Bob LaPrade does that a lot. He has the same x-ray tech. We have about 150 x-ray techs. So, but certainly in the OR, I get my stress x-rays done by myself. And that really helps me guide. And I always use big C-arm whenever I do a PCL or any multi-leg. So, this is something that we kind of heard of. How do we understand the medial side? It's the superficial MCL, the deep MCL, and the POL. They're three distinct structures. And then they have their relationship to the menisci, and you have the coronary ligaments. And then you have the five-headed expansion, the semimembranosus. That's also important. And then also you want to think of how the PES inserts distally and that relationship and then that layered concept. And then the last anatomy, you have to always understand where saphenous nerve and vein are and where your infrapatellar branches are. I always try to like to keep some of those big branches. But understanding the anatomy and the layered approach of the medial side is really critical. You can make some of those extensive Rick Hatch portals, which is what I like to do as well. Mark Miller, you taught me, surgery is fun when you can see. So don't ever be afraid to make big incisions. When I was training, it was all about doing small dual window MCL reconstructions. And I never do that because then I can't get a deep MCL construct. I can't see where the MCL is. So I'm always about making big incisions. Where does the superficial MCL really go? And there's a lot of data and a lot of debate here. People used to think, and Rick kind of implied it, that it was a little bit off the epicondyle. I think Andy Williams and Professor Amos have kind of shown that it's really now the best way to put the superficial MCL attachment is on the most prominent part of the medial epicondyle. That's pretty much well established now, and it will just show you insertion point anatomy is constantly changing. But that's where we are today in 2025. The deep MCL, right? The deep MCL used to just be right below the superficial MCL. The deep MCL is what we detached every single time we did a total knee replacement, every exposure. And like the superficial MCL is a big contributor to valgus forces and direct attachments. Now, the deep MCL has kind of changed its vector. It's gone from right below the superficial MCL to a more anterior construct. And that's all because of Dr. Amos's work. He came to HSS about a few years ago and presented this, and he was pretty much thrown out for heresy and saying that you can't change anatomy, Dr. Wickowitz said, and you're going to capture the knee. So it's amazing. We already heard how a ligament was found, right? The ALL was found. 10 years ago, the MPFL was found. Now we've refound the deep MCL. We are an incredible group of people that we recreate anatomy consistently. I mean, only God doesn't have the arrogance to do that, but orthopedic surgeons do. But I do think there's something to be said of looking at Dr. Amos's work and looking at Andy Williams' work. Both men I trust a lot, and I've used this construct too. Then you want to think of the POL, right? The POL is the posterior structure. And what we heard of that originally, double bundle constructs was superficial MCL and POLs. That was actually all of Bob LaPrad's work. And although Rick didn't say it, he's jumping on the lateral side surgery of Bob LaPrade. He's jumping off the double bundle side of Bob LaPrade. And we're going to tell you why. You want to basically think about this. The medial side of the knee, for the most part, is married to either an ACL, which is AMRI. This is all Jack Houston concepts. Or is it married to the PCL, posterior PMRI? If you are a PMRI knee, your POL, which is much more for rotational control, is a much more important structure. So a classic LaPrade would double bundle make sense. And it's an easy way to do a two-tail limb and one more posterior. If you believe more in ALRI, which is what Andy Williams is talking about, a soccer player's knee, then that's where you'd want to get a limb that's more anterior with your ACL to dampen it, AKA like an ALL reconstruction to prevent rotator instability. That's where you want to do that deep MCL construct. And I can throw you 700 biomechanical papers, but my dad had a knack of making the complex simple. And that's how I want you to understand MCL surgery. With the PCL, do a POL. With an ACL, do more of a short, deep MCL construct. Fixation points matter, and it's fascinating to me when people will talk about the isometry point, talk about a small little dot, and then drill a 10 millimeter socket. So what kind of fixation you use, whether you use a socket, whether you use an anchor, whether you use a screw and washer, that really does kind of change your anatomy. But realize also the screw home mechanism of the MCL. The MCL is not an isometric construct, right? It's tight extension, loose flexion because of the asymmetry of the medial femoral condyle, right? The medial femoral condyle is shorter distally and longer posteriorly. So you have to understand that when you always want to over-constrain the knee. And pretty much, Rick just pointed out, you're saying, well, MCL repairs did a little better than recons because recons probably over-constrained the knee. If you have a good reconstruction, you either over-constrain the knee, and if you have a good repair, it healed. So obviously, getting that dual action makes the most sense. So this is really, where we are with modern day MCL surgery. You could see the classic superficial MCL. You can see a classic superficial MCL with that red anterior deep MCL. You can have an isolated deep MCL. That's always a little bit interesting. And then you can have a deep MCL with a short superficial MCL construct. That's really out there. That's really going to constrain the knee. And then you can have a short construct. So indications we talked about. I always was taught MCL injuries off the femur heal. That's not true. Obviously, they heal better than off the tibia. But, if I see a big hole, I'm going to repair that hole and put an internal brace. I'd be interested to know there are a lot of different types of internal braces. Now there are biological internal braces, not just braids, but collagen braids, and that's something else. On the tibia, I'm always more aggressive to surgically go after them. So this whole concept of that waiting for every MCL to heal is just not true. If you have a sternal lesion, if you have a big medial femoral condyle hole, or if you just have a high-grade injury. And I do believe, I am not a believer of repair. I am a big believer of repair in the multi-ligament setting, and I think Rick pretty much just pointed that out in his last talk. I also am a believer of acute surgery. Although the data is the data, sometimes, what's the best thing about evidence-based medicine? It's not always evidence-based. And I would say if you've done these enough, when you get to them fresh, you have a healing ability. And I'd always, it's much easier to do a manipulation than it is to say, oh, your knee's loose, what am I going to do? Do a revision? So I like acute surgery. I do mostly, if I'm doing with, whether single, double, short constructs, it's all based on what I'm thinking. Is it more an anterior-based injury, an AMRI, or is it more PMRI? So, here's the classic, the Bosworth. This is something I think every young surgeon should learn how to do. How to strip a hamstring, keep it attached distally, put a staple in the medial epicondyle, and then either take your second limb. You can make your second limb into your deep MCL, or you can make your second limb into your POL. This is literally a 15-minute reconstruction, and everyone should be able to know how to do that. And then you can augment your deep MCL or your superficial MCL as Rick pointed out, by using a suture anchor at the level of the joint line. That is the best way to constrain the grafts. If you just have your grafts fixed far apart, to me, that is not how the anatomy of the MCL exists. And here, this is just a single bundle. This is what we did for many years. This, to me, is an outdated construct and it has high failure rates because, again, we're not putting any points of fixation close to the joint line. And even if I do this, I am then taking suture and I'm imbricating the native MCL, and I'm always putting an anchor on the tibia. So this is a fine construct, but you have to modify it to imbricate the native MCL and still get some deep MCL fibers by suturing together. Here's what we talked about, the PMRI construct. This is the Laprade construct. This is that POL, and I did this for many, many years. And then I finally realized, I'm like, this doesn't work for my ACL, my big AMRI guys. And I've stopped doing this. And in the reality, an ACL with medial side injury is much more common than a PMRI knee. So if anything, this should be a much lower number of your double bundle, your double MCL constructs than using a deep MCL graft. And this is that deep MCL graft here, where you have a superficial and you have a deep construct, and it's very simple and easy to do. The question with this one, as we talked about, is over-constrainment. You have to move these knees right away, and I do HO prophylaxis for all MCL surgery. The medial side of the knee loves to turn to bone, so you have to prevent that. So HO prophylaxis is critical for all medial side surgery. And then you can just talk about an isolated short construct. So, I think medial side surgery or ligament surgery in general has conflicting concepts. We want anatomy. That's always great. We always like isometry. Not all ligaments are isometric, but it also depends on your fixation methods. These are all critical in your decision making. But ultimately, we want stability. Sometimes we want to over-constrain with weak fixation so you'll find the right testing length. You never want to over-constrain with a stiff fixation construct. So understanding all these variables have to go into your play. And as I said before, a double bundle POL construct, probably best for PMRI. A deep MCL double bundle construct, probably better for AMRI. And that's the new frontiers of MCL surgery. As my father always says, Rick, this is the first time you're going to hear this line, but you're going to hear it a lot. The eyes only sees what the mind knows. Thank you.